Hello and welcome to today's lecture on SMA, chest, spine, and pulmonary manifestations and strategies for delivering multidisciplinary care. My name is Zachary Corrigan. I'm the Senior Director of Provider Engagement at Children's Hospital of Philadelphia. We have an exciting event planned for tonight. I will introduce our speakers, but first and foremost, just to do a couple housekeeping items. We will be doing 3 different lectures. You're welcome to put your questions in as we go. There's a question feature that everyone should be able to see if you put your questions there. When we get to the Q&A portion, we will read them aloud. Also, the event is being recorded. And lastly, for those who wish to claim CME, instructions will be sent out afterwards for how to claim your CME credit. 3 speakers that we have today are Dr. John Branzima. He's a pediatric neurologist and neuromuscular education director and neuromuscular section head at Children's Hospital of Philadelphia. Dr. Henry Meyer is a pediatric pulmonologist and medical director of Pulmonary Function Testing Laboratory at Children's Hospital of Philadelphia. And Dr. Patrick Cahill is an orthopedic surgeon and Robert M. Campbell Endowed Chair in Thoracic Insufficiency Syndrome at Children's Hospital of Philadelphia. Also joining us for the Q&A section is Dr. Elizabeth Cucella, who's a pediatric neurologist and attending physician in our neuromuscular program at Children's Hospital of Philadelphia, where she completed her child neurology and neuromuscular fellowships. As part of the neuromuscular team at CHOP, she's worked to establish nuesirin and on a Semergen dosing programs and has particular research interests in SMA and Friedreich ataxia. Without further ado, I'll turn it over to Dr. Branzima.
Good evening, everyone. It's a real pleasure to be here to talk about SMA. SMA, there's a lot to talk about right now, and I have about 20 minutes, so I'm going to do my best to bring up some concepts and talk a little bit about what SMA is like in our new age of the disease-modifying therapies. These are my disclosures. As we have a mixed audience, I'll spend a couple minutes going over this briefly. Most of you are probably aware that SMA is the leading genetic cause of infant death. And while it's a rare disease, it's not vanishingly rare. It has an incidence of about 1 in 10,000 live births in the United States. It is an autosomal recessive disorder. And the hallmark of this disorder is degeneration of the motor neurons in the anterior horn of the spinal cord, and in the more severe forms, also the brainstem. We see 3 clinical types in childhood that were defined natural history-wise, but it's important to understand that even within these 3 buckets, there's a huge spectrum of potential outcomes in terms of SMA, even in the natural history. But if we go into a little bit more granular detail about these 3 childhood onset types, the most severe form is unfortunately the most prevalent. It is about 60% of SMA diagnoses will present before achieving the milestone of sitting. These infants rapidly lose their strength and end up needing support for both their nutrition and their respiration very early in life. Without supporting those things, life expectancy would be a maximum of about 2 years. Sitters with SMA have type 2, and so they've achieved sitting but never stand or walk independently. This is about 1/3 of patients. They have a much slower progression of their weakness and often live into adulthood, with about 70% being alive at 25 years of age. Type 3 SMA are patients who have walked at some point in their life, although they may lose that ability as their disease progresses. They have a normal life expectancy. There's also an adult onset form of this disease called type 4 that we won't talk about much more today. And as I mentioned, the hallmark of this disease is degeneration of the motor neuron in the spinal cord, which leads to denervation of the muscle. But if we get into more advanced concepts about SMA, we start to think about the other ways that the lower motor neuron is affected if you have SMN protein deficiency. Besides the innervation of the muscle itself, SMN protein is important for nerve signaling within the nerve that travels out to the muscle. It's important in the integrity of the neuromuscular junction, And many patients who have higher functioning forms of SMA will talk about a significant fatigue component to their symptoms, where they may be able to start off at a certain ability level, but if they try to sustain activity, they start to fatigue earlier than would be expected compared to other neuromuscular disorders with similar levels of weakness. And this is a potential target for therapeutic intervention as well in terms of the neuromuscular junction. And the muscle itself is also abnormal in SMA, both because it's denervated right from conception in a lot of patients in terms of not developing properly with signals from the nerve, but also SMN protein has a role in the function of muscle itself. As we get into more severe forms of SMA, whether it be a form of SMA that presented prenatally and in terms of the progression of the weakness and with severe weakness at birth, or a patient with infantile onset who's quite far into their symptoms, more like late childhood or teenage years in a type 1 patient, we start to see some of the other degeneration that goes on in the nervous system related to SMN deficiency in the long term. This would be things like autonomic involvement, heart rate fluctuations, poor regulation of temperature in the limbs. And in very severe forms, it's also been shown that there can be sensory involvement in classical 5Q SMA, where there's degeneration of the sensory nerves in very severe early onset patients, including abnormal nerve conduction studies of the sensory nerves. All patients with SMA are affected along the bottom of this diagram. So you can see here the weakness of muscles leading eventually to contracture of the joints. One of the hallmarks clinically is absence of the deep tendon reflexes very early in the disease in all of the forms, although patients who walk with SMA may still have some retained reflexes. GI dysfunction is also quite common across the spectrum of SMA. A lot of patients will have dysmotility and also problems with reflux of the gastroesophageal variety. But as we get into the more severe forms, we get to the top part of this diagram. And so in non-sitters or sitters with SMA, the bulbar involvement leads to progressive dysphagia, difficulty with speech, and also respiratory involvement. And it's the respiratory failure, acute on chronic respiratory failure, that is often life-threatening for people living with SMA and tends to be the precipitating event. If there is a loss of a person with SMA, it tends to be related to respiratory dysfunction. Heart abnormalities are seen in the early onset form of SMA. If you have congenital SMA presentation at birth, a lot of those patients will have structural heart defects, and later, as I mentioned, in the course of severe SMA, you start to develop dysautonomia as well. And so again, here you can see that cardiac involvement on this slide, but other systems have also been implicated in SMN deficiency, and the clinical manifestations of this are more debatable. We don't tend to see a lot of clinically measurable aspects of this disease that affect other systems beyond the motor neuron. But this becomes important when you start to think about some of the new therapeutic approaches that we're using in the clinic now. One aspect is liver dysfunction. Low insulin-like growth factor levels have been shown in SMA, and there's a tendency towards iron overload in some severe patients. The spleen and thymus can be dysfunctional in SMA, and this is felt to perhaps be related to the trend that we see of people with severe SMA being more prone to respiratory exacerbations and infections than other people with neuromuscular disorders that have a similar level of severity in terms of their dysfunction. Our patients with SMA are in and out of the hospital more often than people with other myopathies and other things with similar levels of dysfunction. This may have something to do with the immune dysregulation. But anybody who's worked in the clinic with SMA patients knows that the brain is completely spared in this disease for most patients. There's no IQ difference between SMA patients and controls in research, although in very severe congenital onset presentations, again, sometimes we do see some migrational defects in the brain in severe forms. So let's talk a little bit about the genetics of this disease. It's 95% of the time a homozygous deletion of the SMN1 gene, which is found on chromosome 5. In these patients, they'll either be missing just a small part of that SMN1 gene that's important for its function, or the entire SMN1 gene. But the other 5% of patients, it's not a deletion. It's a sequence change or an inversion or some other reason that the SMN1 gene is non-functional. The advantage that people with SMA have is that there's a homolog gene on the same chromosome, chromosome 5, called SMN2. And this gene makes SMN protein or survival motor neuron protein, but not the same efficiency as SMN1. It's only about 10 to 15% efficiency. So what you can see in terms of the phenotype is that the more copies of SMN2 somebody with SMA has, the more likely they are to have a less severe experience of the disease. So people who have the infantile onset form will tend to have 2 copies of SMN2 or even 1 copy of SMN2. Whereas sitters will tend to have about 3 copies, and if you have more than 4 copies of SMN2, you're more likely to be a walker with SMA. But this rule does get violated in both directions. There are people who have high copy number who present more severely, and there are people with low copy number who present more mildly. So there's clearly other modifiers here. This is our best biomarker at this time in terms of predicting severity in terms of the genetics. What we've started to say in terms of lingo in the neuromuscular community is it's well established in the stroke literature that time is brain. And so we say in the neuromuscular field, time is motor neuron now in terms of SMA, because we have interventions that we can give that will preserve motor neuron integrity and also improve SMN function throughout the body. So it's very important to get these started as early as possible. How do we do that? There's a few strategies. Of course, if there's a family history of SMA, you're going to be attuned to that and testing it in siblings of people born to families who have prior experience with SMA. But parental carrier testing and newborn screening are both options I wanted to talk about briefly because they're becoming much more utilized across America and across the world as well. When you're doing carrier screening, most carrier screening tests are looking for that homozygous deletion of the SMN1 gene. And so the challenge here, if you're testing parents, is that some people will have 2 copies of SMN1 on one allele, and they'll have no copies of SMN1 on the other allele. And so even though the test looks at them and says they have 2 copies of SMN1, this person is not a carrier of SMA. In fact, they have that same 1 in 4 chance of passing that 0 copy allele as a person who is a carrier of SMA would have. The frequency of this varies, but it's about 10% in different ethnicities. So it's very important when you're counseling parents who have had this testing to mention this, that even though they may have tested negative for carrier status, they still have a small risk of having a child affected with SMA. Also, this test will not detect that approximately 5% of patients who have another genetic change besides a deletion as the reason why their SMN1 gene is non-functional. But the American College of Obstetrics and also the American College of Genetics both recommend prenatal screening for SMA now. And so many parents are having this testing done. And if both the mother and the father are deemed to be carriers, families do have the choice of prenatal testing for SMA for their fetus, at which point we can have counseling in the clinic for a pregnant family in terms of what having a diagnosis of SMA means, and also what kind of interventions we might be able to offer their child immediately after birth. The other thing that's really been gaining traction quite a bit over the last couple of years since our first breakthrough therapies for this disease is newborn screening. So this map is now out of date. We have about 60% of newborns in the country being screened actively for SMA in the United States right now, with the hope that a couple of larger states will come online soon and bring that even higher. So it's roughly 35 of the states now that have active programs in place. Again, with the newborn screening, it's important to realize that this is looking for double deletion, and so you're not going to detect those 5% of patients who have another genetic change as the reason why they have SMA. I could really spend an hour or more talking about this topic, but I have one slide just to talk about the concept of interdisciplinary care in this disease, which is really critical to optimizing outcomes. What we're trying to do is have a team-based approach where we understand these different manifestations of this disease and look at it from the perspective of multiple specialties to optimize the quality of life for people living with this disease. This would include colleagues like those on this conference with me today, like the pulmonologists and orthopedic specialists, but also other rehab specialists like physical and occupational therapists and speech therapists as well, looking at some of the manifestations of the disease and augmenting function as much as possible there. Swallowing dysfunction and also nutrition are so incredibly important in this disease. Optimizing the nutritional state, being both over and underweight, is not good for somebody living with SMA, and we want to try to optimize their nutrition for their body composition in terms of the amount of muscle that they are really working with. And this takes expertise from nutritionists and other colleagues on our team. There's also a social aspect to this disease that's very important to recognize in terms of the effect on the overall interaction of somebody with their environment in school and childhood, and also in work or other aspects of what they pursue in terms of their leisure activities over the lifespan. We want to make sure that people have the support that they need to be able to function to their absolute best potential, but also deal with any times where some of these stressors may be overwhelming or more challenging for people living with SMA or for their caregivers. There can be an aspect of burnout for caregivers as well, living and caring for somebody who has a significant involvement from a neurologic disorder. And so this is where our social workers and sometimes also palliative care teams can be really helpful in terms of augmenting as much as possible people's behavioral health and social function. And then we also need the help of some people from new disciplines as of the time of our interventional therapies, which I'm going to get to in a minute, because sometimes it's not so easy to get these therapies to the patients living with SMA because of some of the complications of their disease. So where did this breakthrough come from? It's rooted in that initial genetic concept that I brought up, which is that the SMN2 gene is present in people with SMA. And so hopefully what we can do is try to get SMN2 gene to make more SMN protein than it typically does. And this is where our first breakthrough came through in terms of nusinersen therapy. I've got 3 different therapies on this screen, and I don't have time to get into all of the evidence behind the efficacy and safety of all of these strategies. I'm just going to hit a few highlights here. The first therapy that we have access to in the United States was nusinersen, which was approved in December of 2016. This is an antisense oligonucleotide therapy. It's looking at splicing modification of the SMN2 gene to increase SMN protein production. And this is achieved through intrathecal injection. And so the patients need a lumbar puncture to be able to deliver this. It's given in a loading phase over 2 months and then maintenance doses every 4 months, so 3 times a year for life after initiation. And this is approved for all people living with SMA in the United States, from pediatrics right through adulthood. The next option we brought into the clinic was gene replacement therapy or gene transfer therapy with onasemnogene abeparvovec. This was approved in May of 2019. And the strategy here is not working on the SMN2 gene, but rather giving back a functional SMN1 gene through a viral vector to the patient. This has been approved currently for pediatric patients less than 2 years of age. In the United States, in Europe, it's based on weight. The third strategy that's very new and recent in the United States is risdiplam, which was approved in August of 2020. This is a small molecule therapy. It works similarly to nusinersen's mechanism of action in terms of trying to increase SMN2 expression of the cerebral motor neuron protein. But this delivery method is oral or via G-tube. It's a suspension and it's a daily therapy. This currently is approved for pediatric and adult patients over 2 months of age. There wasn't sufficient data from the pre-symptomatic study of risdiplam to submit for the ability to dose younger than 2 months of age. And so really where things become very complex in the clinic right now is if you have if you have a patient that is less than 2 years of age, because we have 3 different therapeutic options here that we need to outline for the families and discuss the different treatments. And it's become also complicated for older patients now, because now we have two therapeutic modalities with nusinersen and risdiplam to discuss with people who are above 2 years of age in the United States living with SMA. So there's different advantages and disadvantages to each of these treatments. But what we've eventually started to see now in the context of having these options in the clinic is that we're modifying the disease trajectory of these patients. And so this classical system that I went over briefly at the beginning of looking at the highest level of motor function that somebody achieves and when they started with their weakness and the rapidity that that's lost no longer applies, because if you're on treatment, you actually start to have a different experience of SMA. Most of us were hoping for stabilization of the disease in the research trials, but the data is clear that with all of the strategies, some of the patients actually show improvements over time, and whether that's development superimposed on a more stabilized lower motor neuron system or augmentation of SMN function in the body, leading to improved function. There's lots of different ways you can look at it, and it's still being elucidated. But what we're starting to look at now is thinking about people living with SMA in different functional categorizations. So we'll still think about that classic triad of either non-sitters, sitters, or walkers with SMA, but people are not limited to a category any longer. If you start therapy early enough, or if they have a strong enough response to therapy when they're not sitting, they may become sitters and eventually even walkers with SMA, when in the natural history, they may have been non-sitters for their entire life. And so as people change between these categories, you can start to think about some of the other manifestations of their disease being more or less likely. For example, walkers with SMA have much less significant respiratory and bulbar involvement typically, whereas non-sitters with SMA are the ones that we really have to be extra careful watching in terms of their vulnerability to respiratory issues and their nutritional status. And so as we start to see this modification of the phenotypes, which we're looking at here in this figure, it's important to remember that people who are diagnosed through methods such as newborn screening or prenatal screening have an increased reserve of potential. If we get the therapy in early enough for them, they'll generally tend to do better. If somebody's been living with SMA for a long time and has had significant progression of their weakness, there's less of a reserve that's there to be able to modify with these treatments. And while we do see meaningful improvements in people who are severely denervated when they start these therapies, they're not to the same extent as those who are started earlier. Bringing back this concept of earlier treatment is essential, if possible. The new orthopedic considerations are really interesting in terms of how the phenotype is changing. If you think about somebody who is destined to be a non-sitter for their entire life in the classical definition, now becoming a sitter in terms of responding to treatment, they're not the same in terms of their overall integrity of both their appendicular and axial musculature. And so we're starting to see different kinds of spinal abnormality, for example, kyphotic posturing in some of the earlier treated patients. Nutrition optimization is also becoming a different concept now that people are more functional with SMA. Before, it used to be that simple things like breathing and doing metabolism of your daily life as somebody who was severely affected with SMA required very careful fine-tuning of their nutrition, because it was very demanding just to go through a simple day of being on respiratory support and other things for these patients. But now these patients are moving more and increasing their metabolic demand, and also patients who are even more functional, sitting or walking, are doing wonderful things with their day about being able to be more functional. But we have to be careful to make sure that they have the nutritional support to be able to do that, and that they're not excessively losing weight, which puts them at more risk of infection or other complications of stressors. And also not overweight, which puts them at a disadvantage in terms of the physics of movement, and also in the long term puts people at risk as they become adults with SMA of some of our societal issues that come up if you're overweight for life, things like diabetes or dyslipidemia. There's a lot of questions about the durability of the three strategies that I briefly outlined in terms of the treatment of SMA. Do we truly have the optimal schedule and dosing for each of the strategies in and of themselves? And is it possible to use them in combination, which I'll talk about very briefly towards the end? It's also interesting to think about the normal process of age span in a person, because once you become a young adult, from about age 20 onwards, you start to lose motor neurons. This is part of normal aging. And what we saw in post-polio syndrome in the past, if somebody had been infected with polio as a child, is that people who had been very stable for long periods of their life in terms of function suddenly would have very big changes in their function with relatively small windows of time as they became adults. This was felt to be due to losing motor neurons that are much more highly reinnervated and so are responsible for a much higher pool of muscle fibers than would be typical of a motor neuron that's lost in the aging process. And so it's a question about whether if we lose motor neurons either through vulnerability that's still there, even in a treated patient in terms of the motor neurons being vulnerable, or the normal aging process will affect people with SMA who have been treated early in life. And then we also have to think about some of the ways that we treat the systemic complications of this disorder in a new light. Do we need to give RSV prophylaxis to somebody who has been treated early with SMN repleting therapy? We also have to be very conscientious about monitoring for any kind of toxicities, both related to potential toxicity of having too much SMN protein, which is something that's starting to get some traction in the basic science world, and also the combinations of these different treatments, if we start to use them, how do they affect different tissues in the bodies differently? We already have some overlap in terms of some of the common side effects that we see with our treatments. For example, transaminitis has become more of an issue in some of the combination treated patients than it was in patients treated in isolation with either gene transfer therapy or nusinersen therapy. Also, thrombocytopenia is an area of overlap between some of the strategies as well. So we have to be very vigilant in the clinic to monitor patients for both short and long-term complications. And so some of the things we still need to figure out with these different strategies. If we're using nusinersen, repetitive lumbar punctures are a challenge, especially in children. Is there a way to implant a device that could make that more feasible for patients? That's been looked at in a couple of studies now. Do we truly give the optimal dose at the optimal schedule? There's a trial about to start of giving a higher dose of the treatment to see if that has a higher efficacy and is still well tolerated safety-wise. In terms of gene transfer therapy, the intravenous dose has a limit in terms of its safety. If you give too much, it starts to cause more and more complications in terms of liver inflammation and other potential side effects. And so there is a trial that is treating with an intrathecal dose for older patients. This is currently on hold due to some concerns about inflammation in the dorsal root ganglion that was seen in preclinical studies. But the safety of giving this higher dose of vector still needs to be established compared to what was seen in the original index research studies. Also, as we start to use these vector-based approaches more in the population, there will be higher rates of antibody titers, it is theorized, in the population, and so many more people may end up antibody positive, which currently precludes them from being treated, although there are immune modulation protocols being developed that hopefully will allow antibody positive patients to still be treated. And we don't know the long-term durability of this approach either, although we do have about 5-6 years experience in the earliest treated patients. In terms of risdiplam, it's still very new. It is still being studied actively in research trials, so they're not completely reported yet in terms of the index studies. But there were concerns that came up in terms of male fertility in the preclinical space that still need to be explored more in humans. Pregnancy effect in women also is a concern, and if somebody's taking risdiplam therapy and wants to become pregnant, that needs some discussion with their neuromuscular specialist. And there were some early phase concerns about retinal issues with an earlier version of the molecule. This did not at all become a concern despite very careful monitoring in the risdiplam research trials. But there's a question about whether using combination treatments or other approaches may bring this more to light again in terms of effect on other tissues. So just very briefly, beyond the motor neuron, how else can we augment this disease? In the clinic, we've been using albuterol for a long time in higher functioning patients, especially to improve their fatigue in terms of neuromuscular junction function. Pyridostigmine or mestinon has also been tried, although not as robust a response in most patients as albuterol. And then there's also some investigational methods looking at muscle augmentation in terms of contraction or muscle bulk with myostatin inhibition that have been actively in research trials recently. And we eagerly anticipate more data to see whether there's other ways that we can target the lower motor neuron to improve the outcomes in this disease. So here is an example of how robust the pipeline here is. This is still needing to be updated more and more as we have more and more going on in this disease state in terms of research. So the questions that are still open are, is there a role for combination treatments? Now that we have these three different options, could they be used together? In the role of a prenatal diagnosis, could we administer risdiplam to a mother who knows she has a fetus with SMA? This is being looked at on the preclinical side and seems to have some pretty promising results, but the toxicity concerns related to fetal development need to be completely cleared before this would be considered. What is the optimal time to start which therapy, and is there a way that we could predict that with biomarkers or with our clinical monitoring? We have to think about the motor neuron-based effects versus the effects on other tissues. We think about something like risdiplam going to the entire body, whereas nusinersen being delivered to the intrathecal space, much less of it gets to the body. And is that an advantage or a disadvantage? This gets back to that concept of involvement of other tissues that still really needs much more research to be able to understand our optimal approach. And are there durability and toxicity concerns, as I mentioned? So we don't have a complete cure for SMA at this point. Even somebody who is diagnosed pre-symptomatically and treated early does manifest some aspects of this disease eventually based on our experience thus far in the clinic, although it's still very early to make a broad statement about that. This brings back the concept of being very clear with families that we want to keep a relationship with them, even if they've been treated very early and a child is doing very well with their SMA. There's still a role for being seen in clinic, both for monitoring for any potential things that we could improve in terms of their function, and also looking for long-term toxicities of some of the treatments that they're taking. We'll continue to have people presenting with symptomatic SMA because of those genetic caveats to the prenatal and newborn screening that I mentioned. And so it's very important to be vigilant for this disease in the neurology clinic or even in the pediatrician's office or an adult specialist as well, much less commonly. And there's still a large population of people living with symptomatic SMA that have had weakness their entire lives that we have to remember when we're thinking about these therapeutic approaches and remembering to study how best to augment their lives. So I hope that I've brought across that this is a new era of SMA that we're living in currently. There's still a lot of research going on and we have more work to do, but there's even more exciting things on the horizon, I believe, for this disease. Thanks very much for the opportunity to speak to you tonight, and I look forward to the questions.
And just as a reminder, as we're changing presenters, if you have questions, we're going to be doing questions at the end, but you can feel free now to put your questions into the Q&A box, and that way they'll be there when we get to the question and answer session at the end.
Okay, I guess I will move on. I'm Hank Meyer. I'm one of the pediatric pulmonologists at the Children's Hospital of Philadelphia, and I'll be presenting on respiratory care in spinal muscular atrophy. So these are my disclosures, none of which have influenced the content of this presentation. So when I think of any neuromuscular disease, and in particular SMA, from my standpoint and what I take care of, we start with respiratory muscle weakness. Then the endpoint from a pulmonary standpoint is respiratory failure, where we would initiate mechanical ventilation. However, it's much more complicated than that. I like to think of three general pathways that patients, through which patients have difficulty. The first is diaphragm weakness. The diaphragm, of course, is the primary respiratory muscle controlling breathing. And then over to the right, supporting the structure of the thorax, the spine, and in the middle, chest wall, the chest wall muscles and ribs. All three of these components control your ability to breathe effectively. And then they're completely interrelated. When you have diaphragm weakness, obviously you're set up for diaphragm fatigue. And also because of an inability to breathe deeply, you can develop low lung volumes. And with an inability to breathe deeply, it's hard to do effective airway clearance. Airway clearance and chest wall motion obviously is tremendously impacted by chest wall muscle weakness, which can then lead to acute respiratory illnesses such as bronchopneumonias and further diaphragm fatigue or respiratory load. And then looking at the interplay between the spine and the chest wall, as the chest wall starts to move less thoroughly, it can become stiff. And in addition, as the spine starts to rotate and curve, you can develop a significant kyphoscoliosis. That kyphoscoliosis interacting with decreased chest wall motion can also add to the impact on low lung volumes and increased respiratory load. And when diaphragm fatigue is it cannot balance the load on the respiratory system, then we have respiratory failure. Dr. Brenzema talked about some approaches to impacting respiratory muscle weakness, in which we've seen pretty dramatic impact on respiratory outcomes. From my standpoint, our approach has always been to start at the end and treat respiratory failure, but now there are a number of different approaches that can impact more upstream things, such as supporting airway clearance as patients start to have respiratory muscle weakness. Then Dr. Cahill will talk about some really exciting novel approaches to managing kyphoscoliosis relatively early in the course of disease. I want to move on and start the clinical aspect part of this talk by discussing airway clearance. And before doing it, it's important to talk about what we actually do when we cough. First thing, of course, is we take a big, deep breath, fill the lungs with air, and then exhale fully. We start to exhale against a closed glottis. And what that does is that allows us to build up pressure on the respiratory system. And then as the vocal cords of the glottis opens, you have an explosive flow of air up the respiratory tract, carrying mucus and other debris that you may have breathed in. There are a number of ways that we can compensate for respiratory insufficiency. The first, of course, is helping a patient breathe in more deeply, helping a patient breathe out forcefully, and then combining those two. And in addition, there's some other accessory ways of supporting airway clearance, both mechanically and pharmacologically. So for inspiratory assistance, there are a number of ways that we can do this. We can use a device called intermittent positive pressure breaths, in which we apply an inspiratory pressure to help hyperinflate the lungs and increase alveolar filling, and in doing so, that helps to increase airway caliber. You can also do something non-mechanical called breath stacking, where you use a mask with a one-way valve, and a patient with still relatively intact inspiratory muscle function can do a sequence of inspiratory efforts until they can't breathe in more deeply. This allows them to breathe in much deeper than they do on a typical tidal breath. So these are three devices that we have for doing inspiratory muscle assistance. The device at the bottom right is called the Alpha 2000. It's a device that's fairly popular in France and in some other European countries, and it does just simple breaths in. The device over to the right is a mock-up of a breath stacking device in which the clear tube to the right of the Y that has a red line on it. That's a one-way valve that allows air in. And then the longer device that has two black arrows to the left is an expiratory valve that's set at 40 centimeters of water. So it allows the patient to breathe out if they breathe out forcefully, but it also helps the patient to be able to maintain air in the respiratory system. That mask will go over the mouth and nose, and the patient will be instructed to take a series of idle breaths until they're not able to breathe in any more deeply. Then the mask will be removed and they'll be able to exhale fully. The device in the middle at the top is called the mechanical inexsufflator or cough assist. This is the T70 version. And this device allows you to do a series of inspiratory efforts. You can also switch it to do inspiratory and expiratory efforts to do a full cough maneuver. You can do expiratory assistance by doing what we call a manually assisted cough. The two images or cartoon images on the top are at rest, with the patient soon to get a compression of the chest on the left or the chest and abdomen on the right. The bottom images are on exhalation with pressure being applied to the chest on the left and the chest and abdomen on the right. So you can combine both inspiratory and expiratory assistance non-mechanically by doing breath stacking and then switching to manually assisted cough. There are plenty of patients that are able to do this. It just requires a committed caregiver and a trainer at the home medical institution that can provide proper training, education, and support. More commonly, at least in the United States, we use the mechanical inexsufflator, which I mentioned earlier, which allows you to apply both a positive pressure breath to augment inhalation, and then shift to negative pressure to augment exhalation. So this is the cough assist again at the bottom right. And so what we do is we provide cycles of inspiratory pressure, and the typical therapeutic range is between 15 which is really just a starting pressure, up to 50 centimeters of water, which we rarely use in pediatrics, but can be used and has been used in adult practice. You'll apply the pressure and hold it for about 1 to 2 seconds to allow the air to distribute, hopefully behind atelectatic airways with mucus plugs. And then you'll shift to an expiratory pressure of usually the same pressure, the negative phase pressure to what you applied on inspiration. And that's also to be held for 1 to 2 seconds. Typically do 5 cycles of 5 breaths, and then pause and allow the patient to either expectorate or, if needed, suction, and then do 5 sets. This is, of course, modifiable based on what the patient's needs are. And there's no set limit to the number of breaths that can be given at any one treatment or the frequency at which the treatment can be given. I want to shift into talking about mucus mobilization as an augmentation to cough assist, because any mucus mobilization moves the mucus in the respiratory tract but does not move it out. That requires an intact cough, which is why using the cough assist or a device like that is the critical primary component of doing airway clearance in patients with neuromuscular disease. So there are 2 devices up here. The device on the left is called intrapulmonary percussive ventilation. It's a nebulizer that's administered under pressure with vibration. The nebulizer allows you to give a patient saline or some other type of medication that can help to thin out and break up mucus. The vibration can help to shear mucus off the airway walls, And the pressure helps the patient to keep their distal airways open. And the three of those things together have been shown in some neuromuscular patients to have additional benefit above the cough assist. The device to the right is called high-frequency chest wall oscillation, which is exceptionally popular in the cystic fibrosis community because it's a fairly simple device that you can place over the patient, and it doesn't require any caregiver support. It's often requested by parents, though, as is the case with IPV, it requires additional airway clearance with a device like the cough assist. In addition, there are a number of other medicines that we can use. We have mucolytic agents to help thin mucus that we largely have borrowed from the cystic fibrosis armamentarium. The first is called Dornase alpha, trade name Pulmozyme, and this is a medicine that helps to cleave cellular byproducts of infiltration when you have an active infection in the lungs. So patients with cystic fibrosis have chronic bronchitis. The cellular debris is largely neutrophilic DNA, and so Dornase alpha or Pulmozyme goes in and helps to cleave that DNA and has been shown to make mucus, the purulent mucus, much less viscous and easier to clear. In addition, there's hypertonic saline at concentrations of 3 or 7%, the latter of which 7% saline has been shown to be very effective in cystic fibrosis at clearing secretions by humidifying the secretions from the higher concentration of saline. 3% saline has been used for many, many years, not in cystic fibrosis. And so both of those can be effective. The only issue with hypertonic saline is that it's a non-selective humidifier. And what I mean by that is that it humidifies any and all mucus, whether it's thin, thick, or normal. And it's important to keep that in mind because it's important to stop it at some point, because if you don't, then you'll simply be creating a larger mucus burden for the patient. In addition, there are three other categories. Sometimes patients will either underclear secretions or in very rare situations actually salivate too much, and we can use anticholinergic, antisalivary medications. Patients with neuromuscular disease can certainly have allergies, and so antihistamines are important to consider. And patients, as Dr. Brenzema mentioned, who have spinal muscular atrophy are prone to having gastroesophageal reflux, and when one refluxes, that can cause you to salivate and also increase upper respiratory secretions. And so anti-reflux therapy with an antacid or even a prokinetic medicine can be very effective. I want to shift into talking about respiratory failure. The support of respiratory failure comes in two components. The first and most important is actually in the category on the left, the interface. How does the air actually get into the patient? By far the most common way that this is done, in particular at initiation, is a nasal mask. However, we also have the capacity to use an oronasal mask over the mouth and nose for patients who aren't able to keep their mouth closed at night. For daytime support, we can use an oral interface for mouthpiece ventilation. And for patients that have continuous support or require high pressures, there's an opportunity or an option to have a tracheostomy tube placed. There also is the capacity to use full body or negative pressure ventilation in selected situations. The most common type of ventilator support is pressure ventilation, which has been around for about 20 years and is quite effective. The most common type of pressure ventilation is positive pressure ventilation, using something called, using something like bilevel positive airway pressure. There is negative pressure ventilation, as I mentioned, that can be used in rare circumstances. And volume ventilation is really only used when you have a closed circuit, such as a patient ventilated via tracheostomy tube or endotracheal tube. So there are a number of different types of nasal masks, and this is a slightly old slide, but it gives the general categories. The ones on the top are largely silicone-based and have a little baffle between the body of the mask and the patient's face that is set to inflate when the mask is pressurized with air from a ventilator. The mask in the middle on the bottom and the left on the bottom have a gel-filled interface that can be molded around the patient's facial contour. The mask in the middle was made to fit under the nose in adults. However, we found that it could be used to fit over the nose in a lot of our infant patients, and was the first mask that we really were able to have success using in infants. However, there are now masks that are made specifically for children, in part because now bilevel positive airway pressure units or non-invasive ventilators are FDA approved, and mask manufacturers have seen that there's a clear market for them. There also are masks that, interfaces that can be attached under the nose, or cannula interfaces, which allows a better line of vision for patients. This is mouthpiece ventilation attached to one of our ventilators that we commonly use called the Trilogy. This articulating arm can be attached to a wheelchair, as is the case here. It can be attached to a desk and can be attached to a chair, wherever the patient may be. Then it can be bent to place right at the patient's mouth. So for a patient that has very poor head control, all it really takes is opening their mouth, moving slightly to the side to put their lips around the mouthpiece. And when they're done taking breaths, they can open their mouth and let the mouthpiece fall to the side. There are two general types of ventilators. These are bilevel positive airway pressure units, or BiPAP units, that are used solely for nighttime use. And the motors that produce the pressure are made only for intermittent use. For patients that require daytime and nighttime support or continuous ventilation, there are more substantial units that have pressure generators or motors that can be used continuously day after day after day. They happen to be about 3 times as much as the BiPAP units. They're really only recommended for patients that truly need continuous ventilation. So I want to finish with a few slides on acute management. And as Dr. Benzema said, most of our patients with spinal muscular atrophy, as they develop respiratory failure, often will have an acute episode that leads to morbidity or mortality. And so the way I like to think about it, we've talked about 2 things that go wrong from a respiratory standpoint. We talk about airway clearance, which we can track with an outcome called peak cough flow. Then we look at ventilation, which we track by carbon dioxide. As time goes on, both of those can become abnormal. And there are certain thresholds that we look at for peak cough flow over on the left and for CO2 over on the right. And we can define grades of severity of deficiency, where you might have a mild difficulty with airway clearance with a peak cough flow below 270 or an end-tidal CO2 above 45, and a much more severe problem with with further abnormality. One of the challenges is that we typically evaluate our patients when they're well, and if they're well initially, when they get sick or when they have an additional stress, such as going to the operating room or an acute illness, their capacity may drop to the point of failure. And it's important to keep that in mind, because even patients who during a clinic visit may not have clearly defined deficiency, when they become acutely weak during an illness may. And so in summary, I want to finish with 2 more slides talking about the general approach when patients get sick. The first and most important thing is to increase airway clearance with the regimen that the patient usually has, including cough assist, additional physiotherapy and suctioning, sometimes adding on pharmacologic therapy with things like nebulized normal saline and albuterol, and then of course treating the infection with antibiotics and now antivirals if appropriate. And finally, one of the biggest things is supporting ventilation. And when a patient with neuromuscular disease shows up hypoxemic in the emergency room, it's absolutely critical to support ventilation and identify whether the patient is in fact in respiratory failure. Once respiratory failure is supported with ventilation, then it's okay to add in additional supplemental oxygen if needed. It's absolutely wrong to initially start with supplemental oxygen because it can alter a patient's drive to breathe. And so treating acute respiratory insufficiency with both airway clearance and mechanical ventilation is absolutely critical. And so I'll finish with this, and I will turn the presentation over to my colleague, Dr. Cahill.
Great. Thank you. Thank you very much, Hank. For this last part of the presentation, I'm going to also introduce my colleague and partner, Dr. Jason Inari, who's on the faculty. Between the two of us, we run the Center for Thoracic Insufficiency Syndrome at the Children's Hospital of Philadelphia, and that's a center of excellence that is focused on taking care of children with spine and chest deformities that are at risk for respiratory problems, and certainly SMA falls into that. So, and I want to congratulate those of you that are orthopedists that are on tonight's presentation. I think about a third of the registrants were orthopedists. I think SMA, until the emergence of disease-altering agents, was an afterthought in pediatric orthopedics. But that's completely changed, and it's come to the fore as maybe the most important neuromuscular condition that we're thinking about in pediatric orthopedic surgery. Certainly, if we look at the history of our field, which is about 80 to 100 years old, it started with polio, and then probably the last 30 years or so, it's largely been a field dedicated to taking care of cerebral palsy as the main neuromuscular condition. And now I think we're on the dawn of the SMA generation in pediatric orthopedics. So for those of you that are in our field, congratulations for being part of this. And I just want to encourage you to participate through the Q&A part of the app here and submit some questions. And Jason and Ari will be trying to answer those as we go. And I'm very interested in what everybody has to say, because there's very little evidence to support what we're doing or to guide what we're doing. And I'm interested in people's experiences as we start to navigate these areas and figure things out. So these are my disclosures. I am a consultant for NuVasive Spine, which is a spine implant company, and one of their implants will come up in a couple of the slides later. Also, there's a assessment tool that our university recently filed a patent for, and I was one of the innovators named on that patent. So I should disclose those two things. So we'll talk really about the axial skeleton manifestations and treatment and assessment during this part of the talk. But I would be remiss to say that that we are working alone, and as my two previous co-presenters have mentioned, this is really a multidisciplinary approach to this complex disease and this complex array of patients. But when we look at it from the orthopedic standpoint, Dr. Meyer had a very similar slide looking at why patients have respiratory problems in SMA. As the orthopedist, I had to distill that down to even a simpler slide. So there's really three things to think about: the rib deformity, the spine deformity, and the respiratory muscle dysfunction. And these are the three things that contribute to the main problem in SMA, which is respiratory failure, or the thing that's the main contributor to mortality. But as an orthopedic surgeon, there's really the only things we can fix really are structural problems. So while some of the pharmacologic and disease-modifying agents that Dr. Bransima talked about can address the muscle weakness, I'm really going to focus on spine deformity and rib deformity throughout my talk. Scoliosis is a very common manifestation, almost ubiquitous for those patients that survive long enough. And we'll talk a little bit about the incidence and the onset. So in the young patients before age 4, the average Cobb angle, which is the main way we quantify scoliosis, it's sort of a measure of how big of a slice of a pizza their curve is 40 degrees. And that it climbs to about 83 degrees, which is an extraordinarily high magnitude by the time they reach skeletal maturity. And the pattern of that scoliosis is pretty typical of other forms of neuromuscular disease. It's most likely a C-shaped curvature, although in a third of patients it can be an S-shaped curvature where it deviates one way in the thoracic spine and the opposite direction in the lumbar spine. Rates of progression, again, are on the very high side for other conditions that have associations with scoliosis. 5 to 15 degrees of progression per year. And it seems to be faster in those patients that are non-ambulatory, which is intuitive because those patients probably lack the trunk muscle control to try to stabilize their spine. And one of the big questions that we have in our field is, are these disease-modifying agents modifying the skeletal manifestations of this disease? And it seems like, at least anecdotally, that they have not been modifying the incidence of scoliosis, nor, as far as we can tell, the rates of progression of scoliosis, although better research needs to really verify these suspicions. One of the big things that we want to know is, does spine deformity affect pulmonary function in these kids? And there is some good objective data that says indeed it does. And there's about a 5% reduction in vital capacity for every 10-degree increase in scoliosis. That's been correlated by a classic study. And then the other important thing that is that we're really paying a lot of attention to, which is something that's unique to SMA and not seen in other neuromuscular conditions, is something called the collapsing paracel deformity. It was first described by Robert Campbell, who is one of my predecessors here, and for whom our Center of Excellence is named. And it's really a severe vertical declination of the rib. So if you look at this rib right here, that's almost completely vertical compared to the normal, almost horizontal orientation that ribs should take. And it leads to a narrowing, lateral narrowing of the thoracic cage. And there's a lot of unknowns with this that we're trying to establish with our clinical registries. When does this first appear? What pattern does it take? What are the rates of progression? How do we even quantify this deformity? And does it precede or come after scoliosis? And what impact does it have on pulmonary function? And all of these questions lead to, when should we or should we at all intervene on this specific aspect of SMA? So my colleagues at Boston Children's published this way of quantifying spine deformity. And the most typical paracel deformity is where there's a narrowing of the upper ribs on the AP x-rays and a relative preservation of the lower T12 width. And so they look at that ratio and have correlated that with pulmonary function. Now, that's not the only pattern of deformity. Sometimes it's unilateral collapse. Sometimes all of the ribs collapse equally, not just the upper ribs. So we have come up with an index to try to address all of these issues, and we measure the relative widths at different levels of the spine. We try to control for those patients that have scoliosis and things like that. Ultimately, what we found is a score that can be that is reproducible among different practitioners, and that seems to correlate well with pulmonary function, at least statistically significant correlation. So we're excited to finally be able to measure this deformity and confirm that it does have a negative impact on our patients, so that tells us we should probably be treating it. But again, we would like better assessments of our patients, particularly these young patients where we first start to see scoliosis and collapsing paracel deformity. It's hard to really quantify exactly what's going on pulmonary function-wise, so that's led to this quest to develop a new assessment tool for pulmonary function. And I'll just talk about some of the limitations with spirometry. Is that it requires our patients to have the maturity to be able to participate with the exam and give forceful exhalation, and things like that. And also, it's a summation of both the right and left side. And when we're thinking about surgical decision making, we really want to address areas of pathology. So we would like a little bit more regional and granular data when we're thinking and planning for surgery. So that led us to develop this tool, which ideally was going to be a tool that could capture and give us information about pulmonary function in patients without their participation. So they can just lie there free breathing, and it can give us regional information about what's going on with the relative contributions of the diaphragm on one side versus the other in the chest wall, and things like that. So that's essentially what we've done. It's an MRI scan that that takes many, many cuts at different levels of patients while they're breathing quietly, and then through the miracle of image processing, assimilates a cinematic loop of the respiratory cycle. And from that, we can derive objective data that's accurate to within 1/10 of a cc about volumetric changes that are going on during the respiratory cycle. And so these are some of the measurements that we can obtain. We can get the left lung versus right lung and relative contributions to from the diaphragm and from the chest wall. And reassuringly, while this is a free breathing sort of not a maximal respiratory effort, so it's not a 1-to-1 correlation with spirometry, it does have a strong correlation when we look at end expiration of actually it's the bilateral lung volume. Sorry, I highlighted the wrong field here. The bilateral lung volume at end expiration has a strong correlation with functional residual capacity. And then we applied this to a small number of young neuromuscular patients, and when we looked clinically, we had a hard time even quantifying any response to our surgical interventions at some of these parameters, other than maybe a slight decrease in respiratory rate. But then when we applied this quantitative dynamic lung MRI score, we were able to show, and we have some normative data, so we were able to derive z-scores. We were able to show that we were able to improve some of these volumes by 3.5 to 5 standard deviations closer to normal. And we can get some good qualitative data as well of the respiratory cycle when we just look at the lungs and look at the differences in the relative size qualitatively. And we have some sort of stylized schematics to look at what our patients' volumes look like pre and post-operatively against normative data, and then post-operative versus normative data as sort of an assessment of how close we restored these children to normal volumes. So I'll switch now and talk about surgical management or management of scoliosis and chest deformity. At our institution, we're largely against bracing. We think it probably exacerbates the rib deformity and probably does not do a good job at controlling the spine deformity, although there may be some benefits functionally to supporting those patients that are not sitters. So if we look surgically, though, at what we're going to do for our SMA patients, we want a treatment that controls the scoliosis, controls the parasol deformity, is physiologically as least intrusive and involves the least number of repetitive surgeries as possible, and then allows also for impact of the spinal canal for nusinersen administration, and ideally without even requiring imaging. So if we look at some of the various treatment options, historically spinal fusion was the mainstay. For those patients that survived the first decade and had spine deformity, that's when they would get a spine fusion, because spine fusion will eliminate any future growth. So we didn't really apply that to the very young patients, but that left most SMA patients without treatment because a lot of the type 1s did not survive to skeletal maturity. Although there is some good data that showed that having a spinal fusion did slow the rate of decline in pulmonary function. So there is some evidence to support control of spine deformity independent of controlling the rib deformity. So spine fusion really controls that, but doesn't address the other issues. It's also incredibly morbid. It's a long surgery with large amounts of blood loss. Many patients are ventilator dependent for long periods of time afterwards, if not forever. And it also doesn't control the rib deformity that we talked about. So then if we start looking at some of these other, so it controls the scoliosis and avoids repeat surgery, but doesn't tick some of those other boxes. So many of you may have heard of growing rods, which are rods that can be adjusted with a surgery every 6 months or so as the child grows. This is one of the only examples of these I have in my files, and in a SMA patient, the construct would go much further distal in the spine, which would preclude access to the spinal canal, and it still requires repeat surgery. So our predecessor here at CHOP, Bob Campbell, invented this device called the Vector to treat patients with conditions like SMA. So I'll show this example of a patient with type 2 SMA, severe deformity, that we use these rib-based anchors rather than attaching to the spine, and then pelvis-based anchors distally. that allow us to distract and straighten out the spine. This surgery takes about 2.5 hours and has about 40 cc's of blood loss rather than about 500 for a spine fusion. They do have to have repeat lengthenings though, so it doesn't tick all of our boxes. But there is some good evidence that it may stabilize some of the physiologic problems such as weight and other things. So one of the evolutions that we had to try to further address the parasol deformity were these gantries, which are wide lateral supports for the rib cage that we can affix around the ribs laterally when we implant these. These are those devices there, and they can actually be distracted to sort of open up the parasol, if you will, at the time of surgery. And so this is an example of how these are supporting those ribs there. And these cases right here show this is an example of a child that had a rapid progression of their parasol deformity that we treated surgically. And this is the presentation that shows a relatively small chest, but then within 9 months the thorax collapsed even further. And so we undertook surgical management to re-expand the chest. And notice also that this allows us to have access to the spinal canal, really even without imaging assistance, because we stay far lateral, whereas other interventions do require spine fixation. So this is that patient 6 months post-op. You can see much greatly expanded thoracic cavity, good symmetric diaphragm motion, and actually even a slower respiratory rate. And so these are some of the things that we saw in this particular patient. We saw great increase in not only diaphragmatic excursion, but chest wall excursion as well. And then the last innovation that we had was to add in these magnetically activated growing rods. These were first approved by the FDA in 2014, and I was the first surgeon in the U.S. to implant these under the FDA approval. And this is the device made by the company that I consult for, so I should disclose that. This is what, instead of having surgery every 6 months, this is what that medical treatment looks like. They come into our office, they load up their favorite YouTube video, and they spend about 1.5 minutes getting the devices adjusted while they're awake via magnetic intervention. So this sort of the pre and post-op look there. So I think we've finally ticked all the boxes. And I'll close by saying, for those older patients that have already had a spinal fusion, we've also done some work where we open up windows in that fused mass of bone to allow access for intrathecal injections future. So a lot of exciting things, but a lot to be learned still in orthopedic management of SMA. Thank you very much.
Fantastic. Thank you so much, Dr. Cahill, and to all the other speakers. So we're now at the Q&A portion, so we welcome and encourage folks to use the Q&A feature to post any questions.
Maybe I can start with the questions from my other co-presenters. I'm curious what your experience has been in terms of the response to some of the treatments that are now in the clinic in your area. You know, what do you think the realistic expectation is of a response to nusinersen or a response to gene transfer therapy if somebody already has pulmonary or orthopedic manifestations of their disease?
I'll start. This is Hank Meyer, the pulmonologist. In my experience, which sort of mirrors the clinical data that's been presented both for nusinersen and an asthma gene, abaparvovec, the earlier you intervene, the more likely it is that you can significantly alter respiratory progression. And in some of the patients with SMA1 who were intervened on, in the first 3 to 6 months of life, they can get to the point where there's almost prevention of respiratory insufficiency. That promise, however, isn't necessarily there for patients who start therapy later in life or with significant disease progression. However, in those patients, one of the things that I've seen quite a bit is improved bulbar function and swallowing function, which leads to an ability to better handle secretions during an acute respiratory illness. So that's really the most significant outcome that I've seen.
Yeah, I'll say that I don't know that I've seen yet modification in the incidence of scoliosis. And I don't know that I had a finger on our SMA patients prior to nusinersen to know exactly kind of when, or get a feel in my own mind when scoliosis onset occurred and the degree of progression. I will say that it seems like the scoliosis is ubiquitous and the progression seems to be similarly variable, whether the patients are having a response other ways to some of these disease-modifying agents. So from an orthopedic standpoint, I don't think we're seeing much modification of the disease, but the caveat being that we didn't treat the orthopedic manifestations before because of the natural history of the disease. And now the life expectancies are increased, so we have to find ways to manage these orthopedic conditions. And that's the phase that we're at right now. And I'll just look, one of the questions that came in the Q&A section was, with a very young SMA patient, when are you starting operative fixation of the spine with growing instrumentation? And this is the million-dollar question that Dr. Meyer and I debate frequently, and Dr. Inari should chime in on this too. Right now, we don't have a strong right answer for this. I think it's somewhat individualized on the patients based on what's going on with their pulmonary function in decline, how rapidly their spine deformity is progressing, and then also frank discussions with the family about whether or not they want to be proactive or reactive to chest and spine deformity. Some of the downsides with early instrumentation is that there's less soft tissue coverage for these relatively large implants that can lead to wound breakdown and things rubbing through the skin and infections and complications in that way. Also, there's some evidence that the longer these are in place, the less growth and distraction we can get later on in life. So there's some advantages to delaying if we can, but we just don't know. Ideally, we want to develop a better understanding about thresholds for when kids are sort of at the about to fall off the cliff, either with pulmonary function or with progression of one of these aspects of chest or spine deformity. We haven't figured that out. I'd be interested to hear from the other orthopedists that might be on through the Q&A section when they like to intervene. I would say we almost never intervene before age 2, and ideally we get our kids to about age 5 or 6 in my hands. Dr. Nari, any other thoughts on that?
Let me first by saying I think Dr. Brenzem and Dr. Meyer, as well as Dr. Kale, have done a great job giving us a quick whirlwind tour across 3 different specialties on SMA. I think where I've seen a change in the clinic is I'm seeing patients that we never used to see before. So kids that are 6 months of age that the natural history we knew, now we're showing up in orthopedic clinic, and the families are excited because they're getting treatment. And I think we are going to eventually have to deal with that difficult question of, do we operatively intervene when they're 2 or 3 years of age? In my hands, I like to wait. Dr. Cahill, Dr. Campbell, and I looked at the risk of complications in children under the age of 2 versus over the age of 2, outside of just SMA, but in all comers in our CTIS database. And we found that if you're having spine surgery before 2, your complication rate skyrockets. So what I really like to do outside of outside of having a discussion with the family is following the curve flexibility. If the curve isn't stiff and I know that I'm going to be able to correct the deformity later down the line, I like to wait. I like to prevent complications by having the kid get a little bit bigger and let there be a little bit of a larger soft tissue envelope. So we are doing growing instrumentation in these children, but I like to wait till the kid is as large as humanly possible without the curve being too stiff that it's going to make for a much longer OR day.
All right, Jason, I got another one for you through the Q&A slot. Somebody's asking, are you leaving magnetic growing rods with no plan for future fusion? What if the patient is already close to skeletal maturity? And if you do a fusion, are you doing a laminectomy at the time of surgery for nusinersen? Three questions there.
So about 4 weeks ago, I operated on a young lady who has SMA type 2 that was at the in-between age of should we do growing rods or should we do a final fusion? And I've known her for about 2 years now, and we decided to wait because she was still flexible, and we did a T3 to L5 because she had no pelvic obliquity and was able to stand, and we did a 2-level laminectomy that I like to place cross links above and below and basically box out over across 2 lumbar levels for our neuromuscular colleagues to have access to the intrathecal canal for their injections down the line. So yes, I am doing a laminectomy in these children for future nusinersen injections at the time of the fusion. And I will tell you that there are some children out there that have magnetically controlled growing rods with the diagnosis of SMA that aren't being taken out. None in my hands, but I have colleagues around the country that are doing that. I would rather take them out. But if the kids are doing really well, I know people that are definitely leaving them in.
Yeah, so the manufacturer's recommendation is that they not be a definitive implant. And there's concerns for long-term for the devices breaking or creating wear debris over decades. In terms of which patient population has the least risk of being high demand and creating lots of wear debris, this is probably that population, and also who probably have a lower life expectancy even with disease-modifying agents. So maybe this is the population to think about doing that. We don't have a lot of patients that have gotten to that point yet. So, but it's an ongoing discussion because the older they get, the worse their pulmonary function is. So doing a major surgery like a fusion at that point is not a trivial thing. All right, looks like this one is for you, Dr. Bransema. About 7-month-old, AME1 on mechanical ventilator for 7 days. Do you recommend risdiplam?
Risdiplam, yeah. I think where we're at right now is a bit of a challenging place for these questions because the risdiplam data is still being accumulated. And where we have a challenge directly comparing nusinersen with risdiplam is that the study populations were slightly different between the trials. And also the measures that were being measured were slightly different because risdiplam was mostly European-based in its development, whereas the nusinersen data primarily was United States, and there's biases in terms of the scales that are used across the pond, as they say. So, I think they're both viable options, and it's important to discuss all of the different aspects of both of the therapies with the family to think about what their preference might be in that situation of being 7-month-old, but with needing the ventilation already that early, you are implying that this patient is probably more severely affected and so definitely needs to be treated with something as soon as possible. Dr. Kachulia, do you have any other thoughts about that?
Yeah, I mean, I think I agree. I think the most critical factor is really starting treatment as quickly and expeditiously as possible. We certainly have had patients who, particularly when they've had more of an acute decline, we've been able to kind of take them from needing a full-time respirator down to really just using BiPAP while they're sleeping. So when you can institute treatment pretty rapidly, you can still get some significant improvements with that, even if it's not kind of the same as what you get when you treat it early. So really, I think the biggest question is what treatments do you have available and how quickly can you give them? Because it's very difficult at this point to say which individual treatment is most efficacious. And those are some of the questions that we're still trying to look into and be able to kind of come up with an answer.
Looks like the next question is, can we improve lung function? And I think one of the challenges with traditional lab-based lung function testing is that by the time we can do it reliably in SMA-2, where it would probably be of most use, it's often quite low. And at least in my experience, it's difficult, if not impossible, to improve lung function. I think the hope that we have based on the data that's been collected is to attenuate the rate of decline or try and preserve it. And that's really what we're looking for. Having said that, if we broaden lung function to improve respiratory, to include total respiratory function, specifically ventilatory capacity, I think there is a real hope and expectation that we can actually see patients weaned from and have mechanical ventilation discontinued. So I think it's still too early to be able to show that that's happened definitively.
All right, and Dr. Kachula, maybe this next one can go to you. It's from one of my colleagues, Pablo Castaneda. Thanks for a great session. Has anyone seen patients who switch from Spinraza to another disease-modifying drug, and does this have any change in natural history? We recently had a patient like this, and in the time of change, had some deterioration. What have you had patients in your practices switching treatments?
So this has been a very interesting question. Thus far, we have had several patients that have switched from Spinraza to onasemnogene. And we've certainly not seen any decline in their function with that. And if anything, we kind of question whether or not there's a boost, because there may be some period of time during which they're kind of getting more of a combination treatment. We don't really have the timing at this point to see whether or not we would be seeing any type of decline in function from Spinraza moving on to risdiplam, but that's certainly something that we will be looking at. That question of whether or not to transition has been a major one that we're kind of dealing with right now. And a lot of that kind of goes back to how much efficacy have they gotten from their chosen treatment and what are their side effects. And I think those have kind of been the questions that have really been helping to steer that conversation along.
There any other questions? Doesn't look like there's any. So we appreciate everyone for joining us tonight, and we will be sending out a recording of this lecture to everyone who joined. And again, for those who joined and wanted to claim CME, we'll send a follow-up note to everyone with the instructions for how to claim your CME.
Great, thanks.
Thank you. Thank you.
Thank you.